Currently, I have nothing to disclose, but I do have a message from the NSQIP database about utilization of their data. Paraesophageal hernias were historically treated with surgery via an open approach, either through the abdomen or through the chest. With the advent of laparoscopic surgery, these are being more frequently treated through a minimally invasive fashion. Currently, in the setting of elective repair, laparoscopic paraesophageal hernia repair is the recommended treatment of choice by many surgeons across the country. The goal of our study was to then investigate the utilization of the laparoscopic approach in solely non-elective paraesophageal hernia repair within the NSQIP population. Specifically, we hypothesized that the laparoscopic approach in this population would have improved 30-day outcomes when compared to the abdominal and thoracic approach, even after controlling for patient or disease factors. So for our methods, we performed a retrospective analysis of the American College of Surgeons National Quality Improvement Program from files of years 2011 to 2016. We queried the above CPT codes listed, and then we classified patients who underwent a non-elective surgery and then classified them by surgical approach. These surgical approaches included laparoscopic, open abdominal, and open thoracic. The open thoracic did include the thoracoabdominal surgeries. Patient characteristics and 30-day postoperative complications were compared by procedure type, and then we performed a univariate and multivariate logistic regression using that to compare outcomes by operative approach after controlling for patient and disease factors that were available within the NSQIP database. Just over 2,000 patients who underwent a non-elective paraesophageal hernia repair were successfully identified. Overall, 24% of these underwent an abdominal approach, 73% underwent a laparoscopic approach, and 2% underwent a thoracic-based approach. There was an increase in non-elective paraesophageal hernia that were captured every year in the NSQIP database. As demonstrated in the graph above, the laparoscopic approach increased from 72% in 2011 to a total of 81% in 2016. An associated decrease in the open approach was seen starting at 25% in 2011 to 18% in 2016. Looking at patient characteristics, the majority of patients in all groups were female, and beside dyspnea, BMI, and age, there were no statistically significant differences between the patient populations quantified by operative approach. We then also additionally looked at patient characteristics. We did note that abdominal and thoracic approaches did have a slightly higher preoperative white blood cell count, and additionally, patients who underwent the abdominal approach were noted to have a greater percent of cases that were classified as either clean contaminated or contaminated cases. In addition, they also had a greater percent of cases that were deemed ASA class 3 when compared to the laparoscopic approach. We then looked at unadjusted outcomes by procedure type, which is seen here. Patients who were treated laparoscopically had decreased mortality, decreased overall length of stay, and a slight increase in the days from hospitalization to surgery. We did find statistically significant decrease in superficial and organ space infections in both the laparoscopic and the thoracic approach when compared to the abdominal approach. We then looked at patient outcomes, specifically these listed above, and we found a decrease in morbidity than the listed conditions that all reached or did not reach statistical significance except for renal complications, urinary tract infection, and then stroke and CVAs. Of note, the laparoscopic approach did have a greater rate of pulmonary embolism at 1% compared to the abdominal approach. However, this was much less than the 7.4% seen in the thoracic approach. Additionally, we did find that patients undergoing a laparoscopic paraesophageal hernia repair were found to have decreased rates of sepsis and septic shock at the time of surgery. For patients that underwent laparoscopic repair, 76% of those were able to be discharged home, which was greater than any other of the operative approaches. Both results from readmission rates and reoperative rates were similar, and none of those reached statistical significance. We then proceeded to go with a logistic regression for death and serious morbidity. For this, we started with a univariate analysis, which showed a 66% decrease in the odds of death and serious morbidity when controlling from the abdominal to comparing the laparoscopic group. We then proceeded with a multivariate analysis controlling for age, sex, dyspnea, hypertension, and womb class, and we found a 38% overall decrease in the odds of death and serious morbidity. We then went with a logistic regression of a surgical site infection. Both the laparoscopic and thoracic showed a decrease in surgical site infections. However, only the laparoscopic reached statistical significance. In the univariate analysis, we found a 69% decrease in odds of surgical site infection. And in the multivariate evaluation, we found a 73% decrease in odds of surgical site infection, both in the open, deep, and organ space. The final regression we moved to was mortality, and we noted a 53% decrease in mortality and when we performed the univariate analysis, and then was found to have a 49% decrease in the multivariate analysis when controlling for functional status, smoking, diabetes, and age. So in conclusion, through our study, we found an increased utilization of laparoscopic surgery in a non-elective paraesophageal hernia captured by the NSQIP database on a yearly basis. Those who are able to undergo laparoscopic approach were found to have a decreased length of stay, decreased overall mortality, and a decreased risk of surgical site infection. Overall, we do believe that our data supports the continued usage of laparoscopic paraesophageal hernia repair in non-elective cases where surgeons with advanced laparoscopic training are valuable. And these numbers, again, we had here showed a 38% decrease in death and serious morbidity, 73% in surgical site infection, and a 49% decrease in mortality. Thank you. I'll take any questions.
Thanks.